Hello, everyone, and welcome to this webinar on laser therapy for equine patient. So this webinar is brought to you by Mano Medical, and so I will just take a couple of seconds to tell you about the company before passing the hand to Ron, who will be your host for the remaining part of the evening. So Mano Medical is a company that exists since more than 20 years. So our main concern is to bring to veterinarians all around the world equipment that is adapted to the use, that is affordable, and that is fit to be used on animals. So Mano Medical is a team of 19 people, which varies. So we are actually going to be more than 20 right now. And we have a very wide range of products distributed all around the world. So we were created in 1999, and our main specialties are big medical equipment such as X-ray, ultrasound, endoscopy, laser therapy, as well as blood pressure devices, and so on. So we introduced quite a lot of different products in time, so I will not take too much of your time by going into details, but it is a very wide range of products, ranging from heating mats, electrosurgery units, furniture, X-ray endoscopy, surgical lamps, capnograph, lab analyzers, and of course, the subject for which you came here tonight, laser therapy. So here you can see a very nice picture of our latest therapy laser, which if you are interested in, you can contact your local distributor of medical equipment. And you can see an example of an endoscope for horses. So this is our motto. So we are aiming to provide solutions for veterinarians which are practical, cost-effective, scalable, and sustainable. And we do that with a worldwide distributors circuit. We work with veterinarians every day, with wholesalers, and also with some big companies. And if you have any questions, you can contact either your local distributor, or you can also send your questions to export@manomedical.com, and we will make sure that your request is forwarded to the right person. So now I will introduce to you Ron Riegel, who will be the speaker for the remaining part of this lecture. So Ron has got his first therapy laser in 1979, so that is quite a long time before today. And he has founded the American Institute for Laser quite a few years ago now, and he's doing training and lectures on laser, and he travels all around the US to bring knowledge to veterinarians and other healthcare workers about laser therapy. So I think that the best would be for me to stop taking your time, and now I let Ron continue with the presentation. Thank you and have a great webinar.
Okay. All right, so you can see me and hear me, Michael? Is that correct? You can see the screen?
Yes.
Okay, perfect. I'll make it big. Well, thank you everybody for joining us and those who will join us in the future. And thank you, Mano Medical, for an opportunity here to share something that I'm very passionate about, laser therapy, not only in the equine, but my company also helps with the education of all the medical professions and nursing, doctors, chiropractic, the whole everything that's medical. We do a lot of work with athletic teams. So that's where my background comes from here. So a few disclosures. I am the co-founder of the American Institute of Medical Laser Applications. And again, we provide training. And about 4 years ago now, I guess it is, I was co-edited a textbook for laser therapy in veterinary medicine that's offered by Wiley Publications. And I was the co-editor, but also the author of 7 chapters in there. And I published numerous papers and teach not only in the United States, but internationally. I've had the fortunate opportunity to travel to many, many countries. And whenever you go and do something, you always find you can always learn something from everyone. I'm a fellow in the American Society of Laser Medicine and Surgery. I'm a member in the Optics Society, which is mostly physics people that are basically developing new laser systems. And I'm a photobiomodulation board member, and I serve on 1 medical board, now just 1, and about 3 different veterinary advisory boards. And again, thank you, Manomedical, for the opportunity to share my passion here with your audience. So my personal history, as Michael said, is I owned a practice for more than 25 years, and finally somebody came along and wanted to buy it, so I sold it. And I did buy my first laser in 1979. And this is a picture of it, and you can see it is, I should have something in there to give you size reference. It is over a foot, it is over, let's see, 25, 30 centimeters tall. And the power on it though was 1 milliwatt. So again, I started out with a 1 milliwatt laser, and you know, I knew the theory about laser therapy, and I was advised by actually one of the founding fathers of the Veterinary Acupuncture Society to buy this laser. And that's what it came about. So I bought that. And then throughout the years, I started doing a lot of different, types of lasers. I did different powers, and we learned the knowledge evolved. I mean, back when we first started, we were a lot of times on the side of prudence. We were afraid of higher powered lasers. We didn't know what they would do. But now the research is in, and after writing the textbook and everything else, I can give you lots of not only clinical experience, but what's in the literature also. So again, I co-founded AIMLA in 2009, so I've been doing the teaching part for quite some time. But what does a therapy laser actually do? What are the clinical outcomes that we want? Only 3, really. It relieves pain. It modulates the inflammatory response. In other words, we have all 4 stages of inflammation. It's just that the stages are shorter, and it increases the microcirculation. So when you take all those 3 together, there's an acceleration of the body's natural healing processes. And I'm going to show you a little bit about, I'm not going to go into too much biochemistry today. That's a subject all in itself, how it actually works. But we didn't know that back in 1979. That only came around the turn of the century. So what are the 2 biggest questions when utilizing laser therapy is, where do I point it? And this depends on the diagnosis, and often, unfortunately, it's only administered to one anatomical area, whereas often many patients would benefit from treatment of all compensatory areas, especially in the horse. I might treat his hock, but the patient would also benefit if you would also laser his stifle and probably up in his back, his hip, lumbosacral joint, somewhere in there. And then the other big question is, how much energy should I administer? Because every part of our patient here, in this case, the equine, has different anatomy. We have to basically allow and use lasers that will allow deep penetration. And we're going to talk about the physics behind penetration here a little bit during this lecture. And it comes down to dosage, and that's expressed in joules per square centimeter. So it's no different than our pharmaceutical models. We dose lasers in joules per square centimeters, just as we dose drugs in milligrams per kilogram. And again, we want consistent clinical results, and it's dependent on dosage. We allow enough photonic energy to reach the target tissues, administration of this dosage, utilizing an effective technique, and doing it often enough. Those 3 things will give you consistent clinical results. So how deep does a therapeutic dose penetrate? Everybody, I've asked that question probably more times than any other question. And so to get consistent results, it's dependent on the wavelength of the laser, the power of the laser, using the appropriate dosage, giving it long enough at whatever power you have, and the appropriate treatment interval. In other words, do I do it once a day? Do I do it once every 3 days? Do I do it once a week? And then utilizing the proper technique. There's different pieces of equipment require different administration techniques. And we're going to talk about that a little bit during this. So I'm going to hit the high points of a lot of different things during this lecture. And the goal is delivering enough photonic energy deep enough to the tissue to reach the target tissue. Wavelength determines the depth of penetration. In other words, it's the most important factor. The higher the wavelength, the deeper it'll penetrate. We're going to talk about that here in a second. The power determines the number of photons that depth to saturate those tissues, at the depth the wavelength will take it. And then application, of course, that's dosage, how many joules per square centimeter I'm going to give, and giving it enough times using the right technique. So first talk about wavelengths. We have three things, in the body that the laser cannot get through. It's absorbed by hemoglobin, melanin, and water. And anything over 1100 nanometers in wavelength is going to be absorbed by water. And that's why our surgical lasers are actually way up high on the chart there, because we want them to be absorbed by water. So as you can see, we've got a little bit of a therapeutic window right here between 630 and 1100 nanometers. And that's where the therapy lasers thrive. They thrive there because the melanin is at a lower point, the hemoglobin and oxyhemoglobin are lower. So we can get good penetration down through our tissue and absorb it. So I'm going to illustrate that a little further. Now, this is an illustration that I made up. It is not to scale. It is not by any means accurate, but the basic concept is here. This is a proof of concept here that when we have, infrared light, it does penetrate further than those of lower wavelengths. And usually during a live session, I actually have different colored, same powered wavelengths, and I show you with my own hand how they go through there. So anything higher than 1100 nanometers is not going to be very deep in penetration because it's absorbed by water, but right at the sweet spot seems to be between 700 and 1 nanometer. Anyway, power, again, I said the power determines the depth, the number of photons at the depth the wavelength will take it. You're gonna have to excuse me for a second. My slides are automatically advancing, and that's not gonna happen. So let's go and do that. Now that won't keep jumping around while I'm trying to talk. So both these examples here are 980 nanometers in wavelength. 5 watts, only supplies X number of photons at the depth that 980 will take it. Whereas a 10-watt laser will deliver much more photonic energy to that depth. So in other words, our goal is to saturate that tissue. The higher the power, the greater the tissue saturation. And again, I'd like to prove everything that I tell you. It's hard sometimes to prove it remotely, but we're going to take a shot here. So this is a therapy laser that I have in the palm of my hand here. And you can see I have the handpiece on the other side of my hand in my palm, and you can see a little bit of the aiming beam coming through my palm on the first picture. I'm not sure if you can see my cursor or not, but then at 1 watt, when it's at 1 watt, taken with an infrared camera, you see I have very little penetration through that tissue. And then when I turn it up to 5 watts, look how much the penetration is. Look how many more photons are penetrating through my entire palm and showing up on the infrared camera. And it even outlines my blood vessels there, which shows you that oxyhemoglobin and hemoglobin are absorbing some of the light, because otherwise they wouldn't be outlined like that. And then when we turn it to 10 watts, you can see that the area of saturation is much bigger and it's got more power density to it. You can see that the white in the center of it is a lot brighter. And I'm not going to try to explain power density and all those other things to you, but the bottom line is the higher the power, the more saturated the tissues will be at whatever depth the wavelength will take it. So I have the fortunate experience and opportunities to work with Dr. Juanita Anders at the laser. Basically she does all kinds of photobiomodulation work. She's past president of the American Society of Lasers in Medicine and Surgery. Her goal of her laboratory is to work on neurological tissue, the regeneration of neurological tissue. So I got to do a lot of things in her lab. And one of the things her and I came up with is that we made phantom tissue. There's a column here that you can see right in the center of that black rectangle there, and it's made out of powdered milk, gelatin, and water, and put in the refrigerator overnight. So I basically made fake tissue. And the only thing missing is, of course, a dermis and, of course, vasculature. So I took the vasculature and the dermis out of the equation, and I had an on-contact administration on the top of that. And what, again, to illustrate my fact here, my point here about power and penetration is again, this is a combination of a laser that emits 980 and 808. And you can see at 1 watt, I only got 1.12 centimeters depth of penetration, where you could see it on an infrared camera. And when I got up to 3 watts, I was at, almost triple that. And then when I got up to 5 watts, it did not triple, because we do have some, scattering and penetration that did not make it down all the way to that mark. And then 9 watts, we have, much deeper, and 10 watts, we have 16.82 centimeters through my phantom tissue. Now, you got to remember, that's going to be less when I put skin on it, or dermal tissue, and when I put circulation through it. But this gave me a real easy way to illustrate to everybody that power is important. Now, we talked about power, we talked about wavelength. Now we want to talk a little bit about how lasers emit that energy. So they emit in several different ways. Number one being continuous wave, and that's easy to understand because the laser is on all the time. So if I have it set at 10 watts, it's going to emit 10 watts all the time. If I have it set at 1 watt, it's going to emit 10 watts all continuously. Now, pulsing, frequency, and duty cycle are terms that are almost synonymous. And what it means basically, and to simplify everything, it means that the laser is on and then it's off. If you have a 50% duty cycle, the laser is on an equal amount of time that it is off. So it's on, off, on, off, on, off. And so when we calculate the average power, it's half of whatever the laser is set for. So if I have it set at 10 watts, it's the average over the time is only 5 watts because it's on, off, on, off. So in other words, it's a slower way of administering your dosage. And then we have super pulsing, which basically is a very high spike of energy and then back down to zero. So, and these can be emitted also at the same time. We can have one wavelength in a laser emitting continuously. We can have another wavelength emitting at a frequency, and another wavelength emitting at super pulsing. Or the laser will go through and do different cycles. It'll do continuous wave for a period of time, then it'll do frequency at a period of time, and then it might do super pulsing at a period of time. So again, laser is emitting only the portion of the time, but the cells really don't care how the photonic energy is emitted as long as it arrives at their mitochondria. So, the cells don't say, oh no, I'm not going to respond to that because that's a pulsing laser or that's a super pulse laser. They don't care as long as we get it. So that's the whole bottom line here, is to get that down to the cells, to our target tissue here. So it has a very high peak power when you're super pulsing, but a low average power output when it's administered by itself. Now, that's not true when it's administered usually with other wavelengths being emitted differently. So let's talk about application techniques here. Again, you see that this is an off contact application to that horse's neck, cervical region. And you can see that the handpiece is off contact, and you can see the bright power density of the beam right on the dermis there. And we're going to show you here a little bit, a couple of things here about the application general application recommendations. Again, our goal is to saturate the targets. So superficial tissue considerations, wounds, you can see them. So you can utilize lower dosages. You can apply it off contact. You can apply it dosage, continuous wave, whatever you want. But our target is right there. So we don't need to use, massive amounts of wattage or anything like that to treat them because we can see it. When we have deeper tissue, the deeper you go, you have to use higher power and higher dosages. And you, if possible, administer it on contact. And you want to approach those tissues from all possible angles. Now, some people ask me, well, how do I determine if it's, superficial or deep? And I said, well, if you can see it, it's superficial. If you can't see it, it's deep. So if my target tissue is a flexor tendon, for example, that's deep. I can't see it. So I'm going to administer my laser accordingly. I'm going to try to utilize an on-contact form of administration. I'm going to give them a higher dosage than if I was treating a laceration, let's just say right over the deep digital flexor tendon, just through the dermis on a forelimb. And again, if possible, you want to place all areas through a passive range of motion, and I'll go into this more when we get to different areas of treatment here. And we want to treat all joints from every possible angle. We want to treat them all circumferentially around the entire joint because, again, we want a photon to get to every single mitochondria that we can find. So if we don't aim the beam in the right direction, some of them will be missed, and you won't have as good a clinical response or biochemical cascade of events that results in that. And then this is one thing that I'm going to hit home here, because a lot of people you'll see lasering and they'll do it with one hand. They'll just use with one hand. Well, we have two hands. So why not use massage while treating, or putting the area through a passive range of motion while you're treating. So I see a lot of people, usually their one hand is on a phone and the other hand is on the handpiece of the laser. Try to use both hands and concentrate on the patient here. This is a photo that was given to me by a colleague in Japan. And again, this is a visual that I want you to remember, because what this will do is give you an idea of what happens to that beam after it passes out of the handpiece into the patient. Again, we have a very high, very dense area right underneath the beam. That's high power density. But as you can see, it radiates out. It scatters and, moves out from there. But you can see all the way on the bottom that there's a little red dot on the bottom of the container. This is a glass container that contains a powdered milk in water solution. So it's, again, a little bit, has a density so that we can see the photonic energy being displayed. And so this is the model that I teach everybody to think of when they're treating an area. So if I can absolutely cover every area from every angle of my treatment area, I will get a good treatment. This is data based on an N1. This was a 150-pound Caucasian male that they did this. And then when they used a non-contact application technique, they lost 65 to actually 67.75% of the energy that was being emitted from the laser was really just reflected right off the dermis. Never had a chance to penetrate. When you're on contact administration, you lose basically approximately 5% or less. Some of the optics on some of the handpieces are very good. Medical's handpiece is very good and allows, when you use the on-contact ball handpiece, you get a very good saturation and penetration of the tissue here. Now, they're both about the same as far as scattering goes, and think back to my example that I just gave you here. And then our incidental absorption, the pigment and hemoglobin and water, that's about a wash for both of them. But when you're on contact, what happens? If I push my finger onto my palm of my hand, I will have a little bit of a white spot there because I've pushed the blood out of the area. So it's blanching of the blood vasculature that allows that one little incidental absorber to be out of the way. So another advantage to on contact is, and we don't know what that is, nobody's measured that before, but it's common sense to understand that. So then we get finally down to the target cells, and whatever's absorbed is absorbed, whatever happens to the rest of it, whatever other photons come along. Once that metabolic reaction, once that metabolic respiration rate is stimulated by a photonic energy, it cannot accept another photon. So that just transmits on through the tissue to find another area to be absorbed, and then that gets absorbed, and that initiates a biochemical cascade event in that cell. So on contact tissue, you have less energy is lost via reflection, therefore more energy at the target. And massage provides a form of passive range of motion while you're doing it. Just think of a tendon. If I take a really thick, deep, or superficial flexor tendon or deep flexor tendon injury and I push on it, I'm massaging that fibrous tissue while I'm administering photonic energy. Off contact treatment is preferred when there's broken skin or wound. I mean, if you have a wound such as this, which would be horrible, I mean, you wouldn't want somebody to be on contact. It would hurt too much and our patients would object. So above all, do no harm. So you want, it's tender at the treatment site. And the same thing goes with a bad bruise or a strain. The patient may object to having on contact. So you start off contact, and then when possible, then you switch to on contact. And when you want to be sterile. One of the things that I'll briefly mention during this is using it during surgery, using a therapy later during surgery. A lot of people, I ask people that and they said, well, I never thought about that. Well, especially in the companion animal webinar, I'm going to give you several examples of using it during surgery. I have used it during surgery of the equine digestive system when I've had to remove part of the small intestine or colon because of a colic case or an impaction. And then you can actually see, after your anastomosis of the tissue, you can actually see that area pink up, that increased circulation that we want. So simple rule, if it's uncomfortable to the patient, apply the laser therapy off contact. If they can stand it and they enjoy it, then you can put it on contact. So now let's talk about dosage. And it's the ability of the laser to provide enough photons within the tissues to initiate a biological response within the individual cells, and it's a function of the wavelength, the appropriate power, and enough dosage, enough energy being administered. In other words, I have to stimulate enough mitochondria and proper administration technique to deliver that. So dosage is basically energy per area. Energy for photonic energy is measured in joules, and the area is square centimeters. So 1 joule equals 1 watt per second, okay? And laser, again, laser therapy is based on the number of joules administered to a specific anatomical area with specific dimensions. So that's very important. I mean, you want to dose it per area. And there's a lot of little crutches that we use, but honestly, the software that's in Manomedicals and a lot of the other lasers that are on the market is up to date, and it gives you a place to start. So it takes that guesswork out of dosing. It gives you the dosage to start with. You can always increase it, you can always decrease it, but at least it does that initial calculation for you. So number of joules delivered to an area is not a dosage. You'll see sometimes, well, I gave it 200 joules. Well, that doesn't tell me where you treated. That doesn't tell me the dosage. So if I want to treat 100 square centimeters and I want a dosage of 20 joules per square centimeter, I have to deliver 2,000 joules of energy to get that dosage. So if I say, well, I treated that horse's fetlock with 400 joules. Well, that doesn't tell me anything because I don't know how big a horse it is. I don't know how big the area was. That's probably only 1 or 2 joules per square centimeter if I did that. So again, here you can see that the dosage is energy over a specific area. So let's look at some common clinical applications here. We talked enough about the physics and everything else, and I didn't even go into the biochemistry, but common clinical applications. On the head, we have trauma, fractures, temporomandibular joint syndrome. And here's probably one that if you're not using this, you need to, is pharyngeal lymphoid hyperplasia or guttural pouch infections, because you can actually extend the horse's head up in the air and reach that very well. Now, TMJ, I've got a little trick for you there also, is we want to put that temporomandibular joint through passive range of motion, feed him a carrot, feed him a treat. He'll chew on it while you're lasering that joint, and you can get it to go through passive range of motion while you're treating it. Cervical region, myositis, trauma, thrombophlebitis. Soft tissue, myositis, tendonitis, desmitis, anything that ends in itis, and trauma. Foot, laminitis, again, another itis. And joint and bone, I'm going to give you examples of this, but it's been proven in the literature over and over that it, accelerates the healing of fractures. It basically certain types of degenerative joint disease. It breaks that vicious cycle that's causing that degeneration. Osteoarthritis, the same thing. Synovitis, it's going to take the inflammation out of the joint membranes, out of the synovial tissues, and so your synovitis, your synovial fluid is going to return to a more normal level. And spavin, I mean, same thing. It's osteoarthritis of the Hock, really. And then post-operative care. A lot of people don't understand that they can use this over an incision. I mean, surgeons right off the bat, way back before the turn of the century, would freak when I tell them to laser over their incision lines. They said, no, my stitches are in there and they're just very happy the way they are. They don't need any light. And then I would tell them, well, let's laser half of the incision and not the other half. And then when they saw the difference in the healing, they would make a remarkable change and they'd start lasering them all. So again, current literature-based recommended dosages. When we did the textbook, we found that all of our authors were basically using the same dosage without any collaboration between them. So this is non-biased, believe me. We were really, Dr. Godbold and I were really surprised when every single author was in about the same dosage range that we were using and that was, currently in the literature. So wounds, again, we don't need a very high dosage, 6 joules, plus or minus 6 I have on there, joules per square centimeter is a low dose for the equine patient, and you don't have to give that very fast, and the target tissue is right there. But the deeper you go, basically, the higher the dosage goes. So soft tissue, if you're not using 20 to 30 joules per square centimeter, you're probably not getting the saturation of that deep fibrous tissue that may have a lesion on it, may have a tear. And deep musculature, and I'll give you a good example over the hip, for example, if you're not using 30 to 40 joules per square centimeter, you're not going to get that saturation of the deep target tissue. How do I know this? Because I put photometers deep into the tissue and I measured how much different, how many different wattages, how much energy was actually administered to that particular area where the photometer was. Joints, again, it's not like deep muscle tissue, but you still have the dermis to get through, the joint capsule to get through the synovial membranes. And again, you're trying to hit all the surfaces in the joint. So you want to make sure that you have a high enough, not as high as the hip, but as high as that soft tissue. Large joints, again, the Stifle SI joint, lumbosacral joint, something like that, 25 to 35 joules per square centimeter. Trigger points. Everybody asks me sometimes, how to do a trigger point. Well, those are actually, I put 8 to 10 joules up there per square centimeter, but what happens if you usually treat those on contact, and you'll just feel that trigger point, that neuromuscular junction there relax after you've given it just a very small dosage, and you'll feel it relax and disappear. Superficial acupuncture points, 80 to 100 total joules, and deep, the deeper you go, again, the higher number of joules you need. Now, this is to 1 point, and you administer these basically while moving. So you basically, the technique is called circle the dragon, of course it is, and you get some very good results with that. Now, as I mentioned earlier, how do we take some of the guesswork out of this? Because that sounds rather daunting. I mean, it's like when they first came out with chemotherapy for cancer, they were asking us to calculate the surface of the patient, the skin surface of the patient to calculate the dosage. Well, that was almost impossible, but we didn't have any software at that time, so we had to do the math. But now, Manomedical here has the software divided up into species here. You can choose equine, you can choose canine, feline, and a lot of the exotic animals, and the exotics are all divided up into different avian versus small mammals, versus reptiles, that kind of thing. And equine, they give you the dosages there to start with. So we choose equine there, and then we go, musculoskeletal, whether it's chronic or acute. We chose chronic, we chose the carpus, the knee, and then this is the screen that comes up. So the laser automatically tells you that this is a place to start. It started at 10 watts total time, and it's the total energy, 1800 joules is what I'm going to give to that carpus. And it's going to be administered in several different phases. It's going to have a continuous wave, pulsed waves, and so on and so forth. So that gives you a place to start. And then every patient's different. Lasering, each one of our lumbosacral spinal areas on ourselves is different. This gives you a median area to start. So let's talk about some of the head applications here. This is a sketch that I had to do for the textbook. And you can see the first thing I put up in the left-hand corner of that sketch was a way to protect their eyes. So a lot of people have, eye protectors. You can't get a equine patient to wear goggles or, laser goggles, the protective eyewear. But I found that if you took a small black towel, we call it a terry cloth towel, or a small, maybe shaped towel, and fold it up on itself about 4 times, the light is just not going to go through that. And so you're not, risking the eye. Plus, you're not directing the light towards that area anyway. But again, trauma, we see a lot of trauma. So a lot of times, I don't know how they find the ways to do it, but they seem to find the loose nail in the stall, and there's a cut right around their eye. So you can protect their eye and, suture the cut up and the laceration up, and then laser it. Fractures, I've unfortunately seen a couple of fracture cases that this really helps with the relief of pain and acceleration of the healing. And your temporomandibular joint syndrome, again, this is the entire area that you're going to laser. And again, how do you get that joint into range of motion? You feed them a treat, you feed them a carrot. And then, and this is, bilaterally, you want to do this, even though the sketch only shows unilaterally. For pharyngeal lymphoid hyperplasia, you can actually get the horse to extend his head up in the air, and you can cover most of that area. You can aim the handpiece into the guttural pouch area, into the, and for, all around the larynx and pharyngeal tissues. And if you want to test this, scope a horse. I noticed there that Mano makes a really nice endoscope with a picture. I'm sure there's probably a way of capturing that picture. We look down there and we see lymphoid hyperplasia on it. Laser it probably 3 times over a 5-day period and scope them again, and you see a big reduction in the lymphoid hyperplasia that's present there. Dosage, again, around this area, 20 to 25, 15 to 25 joules per square centimeter. Again, superficial, lacerations, not so much. Fractures, yes. Trying to penetrate into the guttural pouch areas, that's where you use your 25 or more joules per square centimeter. Cervical region, again, myositis, trauma, myopathy, thrombophlebitis. This is an initial case here. These are the initial pictures of it. This horse was treated without the laser, and they thought it had resolved, and it was from a perivascular injection by a trainer. And what happened is that they thought it was resolved. The horse was turned out, and extorphs started to swell again. And they called and said, well, can we use the laser on it? And I said, well, absolutely. I said, that's what it's made for. It's made to take the inflammation and swelling out. It's made to reduce the inflammatory response here. So that's initial. This is a 3-year-old thoroughbred. He's had this thrombosis for about 3 weeks duration. And before, he had gotten nonsteroidal anti-inflammatories, and they put ice and warm, moist heat on it. This was done at the Sanctuary. It's a rehab center in Ocala, Florida. So 15 joules per square centimeter, because again, my target's not very deep. 10 watts, continuous wave on contact, 3 days in a row, total joules 7,500 to this area. Now, this is not bilateral, it's unilateral because it only has thrombophlebitis on one side here. So this is after 3 photobiomodulation therapy sessions at 72 hours. And note the decrease in swelling and the increased vascularization. Just look at the difference of what we have here compared to what we had on those initial pictures. And there's after 16 days. So I'm going to move this just in case my picture is in the way there. And now you can see that that has healed up quite nicely after 36 days, but after 16 treatments. And now you can't even hardly tell. And the vein was patent. So trauma, this is an image you saw earlier. This was the initial, and this was after it's stitched up. And we all know what's going to happen. That horse is going to do everything it can to tear those stitches out. So again, that's on September the 16th. So dosage, again, not really a high dose because it's very superficial, 12 joules per square centimeter, 8 watts, CW and pulsed off contact because the horse would bother it. And look, that is in just a little over 30 days. And that's a very, we did 3 consecutive days and 3 therapy sessions every other day, and then 4 sessions over the next 2 weeks. So we basically treated aggressively, and then we basically started to, treat it as a maintenance, and then we basically, phased out the laser therapy. So, it depends on your schedule and depends on the injury, depends on the owner, depends on the patient, but a lot of times you want to get very aggressive. We want to stimulate those biochemical cascade of events that'll get us to healing, and then you can maintain that. So we have just think of an anesthesia. We have an induction phase, and then we have anesthetic levels. So we're doing the same thing with the laser. The shoulder region, again, osteoarthritis of the joint there, trauma, OCD, if the lesion is accessible. In other words, the light has to get to it. Tendonitis, bursitis, bicipital tenosynovitis. And again, it's a large muscle area and large joint. So we're going to use 25 to 30 joules per square centimeter. And I've used that dose for quite a few years now and have not had to increase it. Over the years, the dosages gradually got higher and higher and higher, but we're pretty much at this dose right now that seems to, a higher dose just doesn't seem to, the only thing you're going to lose is your time. You're not going to overstimulate the tissues, but by the same token is, time is precious when we have X number of patients to see in a day, and I didn't find any benefit to a higher dose or even giving it twice a day. Carpal region, this is Pandora's box here. Again, trauma, fractures, degenerative joint disease, osteoarthritis, carpitis. I even had a case of carpal tunnel syndrome that I treated and went on to win and won the Breeders' Cup and then go on to be in the Dubai race for the World Championship. Didn't finish well there, but we did win the Breeders' Cup. But here again, I want to put the joint through range of motion. So I want to do it flexed. I want to administer it on contact. This is showing an off contact administration. When the horse has a very sore knee, you might not be able to do it on contact, but once you can, and you can see by my illustration here that I am basically treating it circumferentially around the entire joint. I'm bringing that handpiece around every possible way. I'm keeping it perpendicular to the dermis, and I'm putting that area through passive range of motion with my hand. Again, here's a case of carpitis. You can see this is a quarter horse with intermittent lameness. DJD, you can see the osteophytes at the radiocarpal, anti-brachial, brachiocarpal, and middle carpal joints. You can see it on this radiograph pretty readily. It had numerous interarticular hyaluronic acid injections. And then after the last one, didn't seem to last very long. So then they started to use laser on it and laser therapy, photobiomodulation therapy at 20 joules per square centimeter at 10 watts continuous wave on contact for over every 48 hours. And this was right after the joint injections. A lot of people ask me, well, how soon after a joint injection? Once you're sure that there's no hemorrhaging going on from your injection site that could possibly bleed more, then it's safe to laser. I have actually injected them in the morning and lasered them late in the afternoon because it's going to help what you're giving there. It's not going to do any harm. So post intra-articular injections, 5,000 joules per therapy session, hand walks for 3 days, photobiomodulation therapy then every other day, and it was back to work in 3 days. In 1 week, it was sound at a trot, back to regular work twice per week for 2 weeks, and that quarter horse returned to competition after that period of time. So 2-week recovery for that kind of radiograph is pretty good. I never had that with just joint injections, but when I added laser to it as a combined, so a multimodal approach to that problem, it did increase it. And again, maintenance was 1 to 2 days, before each show, sound for the rest of the season. They didn't have to inject that horse again. The metacarpal region has, a whole assortment of disorders that can occur here. Dorsal metacarpal disease in the young 2-year-olds that are stressed too much in our country. We race them too fast and too early, which you probably know that in Europe. You're smarter and you don't race the young horses like we do. Splints, suspensory desmitis, superficial and deep digital flexor tendon, tendinitis, tenosynovitis, bowed tendons, inferior check ligament desmitis. Again, higher dosage because, again, even though our targets are very superficial, we still have to get penetration through that fibrous tissue of those tendons. So again, you see this leg in a flex position here, and you can see my little arrows there that I'm giving it as a cross-frictional fiber technique on contact, and I'm also following the direction of the fines or a longitudinal technique of the fibers when I'm administering it. This case I have to share with you because this was my epiphany case. This was quite a while ago. Whoops, sorry, I'll go back one. Boy, it really skipped forward there. There we go. This was March the 10th. It was an 8-year-old warm blood show jumper down in Wellington, Florida. And it was presented with an acute right forelimb lameness after jumping over a hard course. And these were the ultrasounds. That was March the 10th. And you can see by that ultrasound study there that we had quite a bit of damage to that tissue. That's a core lesion. Now, this was way back before the days of stem cells and PRP injections. So what do? We would rest them and hopefully give them time enough to heal. But what the big problem was then, when we only had that to give them and we didn't accelerate the healing at all, what happens? They scar in. And as soon as that tendon becomes scarred, it's not elastic. So what happens? The horse goes sound, we return it to work, and it jumps any kind of height again and tears again. So those were very frustrating cases. But this was the first one that I did this to, 20 joules per square centimeter, 10 watts off contact at first because the horse was very sore. Then I switched to on contact. I gave him 3,500 joules, basically treated the entire area from the carpus on down, 16 therapy sessions, passive range of motion, and hand walking. I'm not a big believer in stall rest. The horse needs to move, and that's how we get normal tissue to reform again. And this is what it looked like in 45 days. So again, quite a bit. So this was my 45-day recheck, and I'm trying to make sure all the pictures are out of the way here so that you can see. I'm not having a whole lot of luck here. Oh, well. Oh, there it goes. And you can see how good healing we have. I mean, that is great healing. Look, there's not one sign of scar tissue in that. And I was like going, oh my gosh, March 10th to April the 26th, that's unbelievable. That's incredible. How can that possibly be? And again, that horse was back in competition at the same level on June the 28th. That never happened. That was a season-ending, if not a career-ending injury before I started using photobiomodulation therapy. So again, on June 28th, placed 6th in the class, same class. Fetlock, again, we have Pandora's box here as far as disorders go in that area. And again, you want to put it, not only have the horse stand, but you also want to put it through passive range of motion, fractures, sesamoiditis, ocellates, osteochondritis, DJD, and then maintaining performance. We have a horse, just like you saw that quarter horse, we maintain it through the whole season with twice-a-week therapy sessions. And that's key. I mean, once you have them recovered from it, you want to use a, aggressive dosage to begin with, then a maintenance dose. You're going to find out. Maintenance is different for every patient. You want to find out what keeps that horse sound the longest. Sesamoiditis, again, 4-year-old thoroughbred, grade 2 lame. Again, several intra-articular injections and systemic Adequan, no injections within the last 30 days, 18 joules per square centimeter. And again, daily for 3 sessions and twice a week for 2 weeks. And it was sound after the 4th treatment. And that's, that's not a severe case that I've seen at the racetracks a couple of times. But again, same dose of treatment sessions after a work and the day before the race, I was maintained the rest of the meet at the racetrack. So again, a way of aggressive treatment and then a maintenance performance here. The hoof, again, dense tissue composition of both the bony tissues and epidermal layer of the hoof wall. Basically, you cannot get the laser into and through the hoof wall or those kind of structures. So you're basically limited to what you can administer through the heel of the horse. So this is a laminitis case here. And again, I want to go through the heel of the horse. I want to administer on contact and around the coronary band. And whatever portions of that anatomy, and that depends on the conformation of the foot, whatever that, photonic energy will reach, that will help it heal. But if it can't reach it, if you have an area that's very deep down in the, a cyst in the coffin bone, for example, or something like that, that the energy is not going to get to, it's non-rewarding to treat those, believe me. So application again to the foot is, those are the ting points that I have outlined with red dots. I want to give a lot of it through the heel of the horse, which you can see on these illustrations. And then I want to follow the coronary band and the lateral and medial, proximal areas there to the coronary band that I have outlined in pink here are basically, I'm lasering the nerve supply to that area. So I'm basically trying to reestablish the nerve supply to that area, reestablish the circulation to that. And again, it provides to the laminitis, you're going to do everything you already do for laminitis, but you're going to basically provide at least a short-term analgesia. You're going to get vasodilation and angiogenesis. What is laminitis besides a vascular event? It's a vascular disaster. That's what I used to call it. Block depolarization of the C afferent nerve fibers. And, again, we're trying to control that pain in the horse, and then we stimulate the acupuncture points at the same time by doing it. The back of the horse, again, primary back pain, I think, is more of a problem than we realize sometimes. Lumbosacral joint pain, secondary back pain to something distal in the limbs. Poor saddle fit. Unfortunately, we don't have as quite a good quality riders as what you do in Europe over here in the States. And I see a lot of, basically myositis due because of the way that people ride. Not necessarily the saddle doesn't fit, they're just poor riders. And exertional, ER, osteoarthritis, performance maintenance. And this is important. And if you don't believe me, do this. Laser, find a horse with a sore back. Palpate the back, get a good idea of the turgidity and the tenseness of the muscles. Laser half the back. Laser one side. And then palpate it again and see what the difference is between that side and the side you have not lasered. And you will be shocked at how much is. Now, how long does it last? It depends on the patient, how much the back has been strained. Is it because of conformation? Is it because the horse is being asked to do something it can't naturally do? Those, are more of a challenge to maintain through the season than that. But again, I'm going to use a high dose. I've used actually 50 and 60 joules per square centimeter on some of these, especially when your back's up against the wall and they have to be sound or they have to be workable, in 3 or 4 days. So we do give them quite a high dose, and it's very successful and it helps quite a bit. If you have access to infrared thermography, it's a roadmap. It answers that question, where do I administer? How much do I give? And again, multiple areas of hyperthermic activity over the spine and lumbosacral joint. That's the white areas on this. And we're right next to the letters there. And again, correspond to palpable soreness and turgidity within the paravertebral musculature. And there was measurements taken. And look, 30 joules per square centimeter CW on contact, a 42% reduction in the areas of increased thermal gradients. In other words, we can objectively measure the response to laser therapy with infrared imaging, and you can see right there, we have reduced those thermal, focal thermal points by 42%. And again, clinically, the horse moved better, palpated, relieved less muscle turgidity and soreness. And that was in 24 hours. That was after 1 treatment. Hip, big muscle area, myositis, trochanteric bursitis, fibrotic and ossifying myopathies. If you can catch these early, they respond. If you're a little behind the 8 ball on those, they're not going to respond very well. So, one of the rules of practice is under promise and over achieve. Well, you tell them, boy, I don't know, he's not going to get any better here. And then if he does, you look like a hero. But if you promise that they're going to get better, or you make some kind of statement that this will help, then they expect it. So you have to be careful how you word some of your answers sometimes. Dosage, again, high, 25 plus joules per square centimeters, and you're not going to get much down into these tissues without treating them on contact. And doesn't matter if it's continuous wave or frequency, as long as you give the right dose. Stifle, here again, some infrared thermographs showing before and 24 hours post the first therapy. And again, OCD, osteoarthritis, upward patellar fixation. Well, you say, how does that work? Well, you're taking the inflammation out of those tendons that are basically fixating the patella. So trauma, fractures, again, ligamentous injuries, and always treat all the surrounding tissues. If you can see my cursor, which I hope you can go all around the stifle joint. You're going to treat all the soft tissue. Where we have a little bit of a problem treating is medially, because we can't get the handpiece up high enough, and a lot of times their stifles are sore enough that they won't allow you to do it. So I'd love you to treat these on contact, but I've had a lot of horses with very sore stifles that you could not treat on contact. So you would treat them off contact for maybe 10 minutes, 15 minutes, and then try on contact again. Let the analgesic effect take place, because it does take place that quickly. And if you can't, maybe the second treatment you can treat on contact. So this was the change in the infrared imaging in 24 hours. And again, always look for secondary compensatory structures throughout the patient. So if I'm treating the stifle, I'm certainly treating the lumbosacral joint. Hock, again, Canian tendonitis bursitis, again, superficial targets, but a joint.
Excuse me, Ron.
Yes.
This is me. Yes. Yeah, just to warn you that we have about 10 minutes left.
Okay, I'm pretty sure I'm going to make it. Okay, but thank you. So again, all these disorders, again, treat circumferentially around there. This is a case of bone spavin that responded at a dose of 25 joules per square centimeter. Again, daily for 3 days and twice a week for 2 weeks, and day before the show is needed. Maintain it through the whole season. Laser loves to heal wounds. This is a 19-year-old trail horse. This lady was a veterinary technician up in Canada, and all she used on this was lavage, moist wraps, and laser therapy, 16 sessions, 12 joules per square centimeter. She took so many pictures. For this, I have probably 40 pictures of this horse's leg through various, and you can see the veterinarian in charge of this never trimmed that flap off, and this is how well it healed. She actually started riding the horse at day 32. Dorsal cortical stress fractures, a lot of what would we normally do, we'd put a screw in this, but these people did not want to do surgery. They basically was economics reasons. And so we started to laser it. And again, 15 joules per square centimeters and stall rest, daily a couple of times, 3 times a day, every other day for 2 weeks then. And that healed quite nicely in 28 days. As you can see, that fracture is almost closed. Acupuncture point stimulation, laser puncture. Here again, we're giving 80 to 200 joules on contact in continuous wave or at a frequency. Actually, I prefer frequency for this, and don't set the laser more than a half a watt to 1 watt and move the handpiece around. And again, this is an area where we're going to treat not only treat this localized area of inflammation here, we're also going to treat the corresponding acupuncture points. This was a study done at the Chi Institute, and again, it showed the stimulation of the acupuncture points with the laser and showed the change in the circulation of the foot. I mean, we're talking these changed almost instantaneously, not instantaneously, of course, but very quickly. And you can see again how that changed the circulation. You can see before and after on each side here that thermography showed that increased circulation around the coronary band when the acupuncture point was stimulated, which was gallbladder 25, it actually cooled that foot down. So laser therapy is a scientifically proven and effective modality that provides what I started with, a relief of pain, modulation of the inflammatory reaction, an increase in circulation, and acceleration of natural healing. So it must be administered using correct application techniques, appropriate dosage, and frequently enough to obtain consistent clinical results. So again, questions? I mean, Michael, if he has any questions, he can ask me right now till we're out of time. But I do want to thank Manomedical for allowing me to share my passion. My personal email is up there, but you also can email Michael at Manomedical and he will get the questions to me. Michael, do you have any questions?
Yes, let me see. Yes, so we only have about 5 minutes left, so we will not be able to respond to all questions.
If
So
you send them to me, I'll email you the responses. Okay.
Yeah.
Okay.
So there is so you can type your questions. There is a section for questions on the side, so you are welcome to type them in there. I have one question. Is the following one? So, Ron, what is the if you had to choose one pathology that you would want to learn to treat with laser, which one would that be for a horse?
Okay. For a horse, wounds. I mean, lasers love to heal wounds. The target's right there. That's the learning lesion. I call it many times. You learn to treat the wounds, and then you work on to some of the deeper structures or whatever. But you'll get that wow. You'll see your results very quickly with wounds because you'll see it heal up. You'll see no granulation tissue form. I've only had to trim granulation tissue probably on 2 wounds once I started using higher dosages in the laser on the wounds. So that's my answer, wounds.
Okay, thank you very much. Okay, so yes, I can see someone typing something.
Okay. So how do you administer laser therapy to a gorilla, which is in the bottom picture there? And if you notice, he's drinking out of a sippy cup. So you can't protect his eyes. So he loves that stuff in the sippy cup. And when the sippy cup's empty, the treatment's over. I've had quite the experiences, let me tell you.
Yeah. Yes, Ron, I have a question. So for how it is considered to do laser treatment from a preventive point of view, like before you make a horse run, is it a good idea?
Okay, that's a very good question. And that's a question I get asked a lot of, and I did not put that section in here due to time. But in other words, what happens? So it depends on the event that depends on what the horse's job is. If you have a reining horse, absolutely, you laser their hocks the day before and even the day of their competition. But I found out the hard way, when you have a horse like a thoroughbred, and they are a fast twitch animal and they have to go flat out, if you give them laser therapy the day of the race, you actually basically, because of the release of all the biochemicals that happens with the cellular reactions and everything, the horses just are not very sharp. They think that's a great crowd today, but they're not interested in really crossing the finish line first. So luckily, the first time I did that was with 3 different trainers and they didn't talk to each other because we didn't do that. I learned in a hurry not to do it the day of the race, but the day before, on most cases, you'll be fine and you'll help because you're decreasing any inflammation that's there to training. You're basically doing a warm-up exercise on a problem joint maybe or a problem tendon. A lot of work on their backs before, no matter what their discipline is. The dressage horses, the quarter horses, of course, and the thoroughbreds, a lumbosacral joint on a thoroughbred, as well as their stifles. A lot of times we worry too much about their carpus and fetlocks on the forelimbs. But doing that the day before the race, they do. It helps them, perform better or perform up to their ability.
Mm.
2 years ago at the Rolex event, which is a, class 4, 4-star event in Lexington, Kentucky, 5 out of the 5 top winners, all 5 of them were using laser therapy every night during that competition. I know that for a fact. So that'll show you how widespread this is used. So that kind of ties into that question that was just asked.
Okay, thank you very much. Well, I think that I don't have any other questions right now. So this webinar will be available for replay on Manomedical YouTube channel. So thank you, Ron, very much. So if anyone is interested in Ron's book, Laser Therapy in Veterinary Medicine, trust me, it is a true Bible of laser therapy. So if you are interested in making your own protocols, get this book. If you had to buy one book, it would be this one.
That's right. And only because I had such good contributors and a great co-editor. Thank you, Michael, and thank you everyone for attending, and I hope it helps you understand what's going on.
Yes, and if you have any questions regarding this webinar or regarding the laser device, please email either Ron at the email address displayed on the screen or Manomedical at export@manomedical.com.
Perfect.
So,
all right.
thank you very much.
Thank you.